Hello, my name is Subin Chayth. I'm a fourth year medical student. I'm here to discuss hand and wrist, an overview of common pathology with radiological findings. So the first thing we're going to talk about is the anatomy of the wrist. And this is just an anterior and posterior view of the wrist and the carpal bones, which are the scaphoid, lunate, triquetrum, pisiform, the hamate, capitate, trapezoid, and trapezium. And these carpal bones form certain arcs. So the first carpal arc is formed by the scaphoid, lunate, triquetrum, and pisiform. They're more proximal portions, which I'm tracing here. The second carpal arc is on the more distal portion of the same bones. And the third one is on the undersurface of the capitate and hamate. And it's important to know these arcs to look for any kind of discontinuity, which may indicate some sort of dislocation. This is just a lateral X-ray view of the wrist, and you can assess certain angles of the carpal bones to assess for wrist instability. So an important angle to know is the scaphoid lunate angle. So I'm going to trace out the scaphoid here. And I'm also going to trace the lunate here, which now makes more sense because it looks like a moon. And the angle of the scaphoid lunate is assessed by drawing a line through the poles of the scaphoid, like so, connecting them, and then drawing a line straight through the lunate. And it's this angle that you want to assess for. Generally, an angle of between 30 and 60 is considered normal. 60 to 80 is considered questionable, and greater than 80 is definitely indicative of wrist instability. So there's other important compartments of the wrist include the extensor compartments, which are on the dorsal side of the surface of the wrist. And the first compartment contains the extensor pollicis brevis and abductor pollicis longus tendons. The second compartment contains the extensor carpi radialis brevis and longus tendons. The third compartment contains the extensor pollicis longus tendon. The fourth compartment contains the extensor digitorum and extensor indicis tendons. The fifth compartment contains the extensor digiti minimi, and the sixth compartment contains the extensor carpi ulnaris. Next, we're going to discuss the anatomy of the hand. So this is just a bilateral hand x-ray. Just important to keep a note of the number of bones. So 10 metacarpals, 10 proximal phalanx, 8 intermediate phalanx, and 10 distal phalanx. When talking about the hand anatomy, we must also keep in mind that there are multiple groups of muscles in the hand. One group is the intrinsic hand muscles. Intrinsic basically means that the muscle both originates and inserts within the hand, and those muscles are listed here. They are the abductor pollicis brevis, flexor pollicis brevis, adductor pollicis, and opponens pollicis. These four muscles make up the thenar eminence. And then you have the opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi brevis. These three muscles make up the hypothenar eminence. Then you have lumbricals, which are muscles that assist in flexion of the fingers, and they originate off the flexor tendons. And there are also dorsal and palmar interosseous muscles, and these muscles are between the metacarpals, and in terms of their function, you can easily memorize the function based on a simple acronym, PAD-DAB. So PAD for PAD. So palmar interosseous muscles assist in adduction, while DAB or DAB, dorsal interosseous muscles, assist in abduction. There are also extrinsic hand muscles that include extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris, flexor carpi radialis, flexor carpi ulnaris, flexor digitorum superficialis, and profundus, and palmar longus. And this just shows different compartments within the hand. You have the thenar, hypothenar, central, adductor, and next we're going to discuss important neurovascular structures, and these include the carpal tunnel. Carpal tunnel is formed by the transverse carpal ligament, which connects from the hamate and the pisiform to the trapezium and scaphoid, and this contains the median nerve. Median nerve is important because it provides sensory information to the first 4.5 digits of the palmar surface, as well as motor innervation to the thenar eminence, which includes flexor pollicis brevis, opponens pollicis, abductor pollicis brevis, and the lateral two limbricals, and as well as the extrinsic flexor tendons. Another important structure is Guillaume's canal. Guillaume's canal is formed by the superficial palmar carpal ligament, and this contains the ulnar nerve as well as the ulnar artery. The ulnar nerve provides sensory information from the palmar and dorsal surfaces of the half of the 4th and 5th digit. In terms of the blood supply, you see the ulnar and radial arteries entering the wrist. They split into the deep palmar arch and superficial palmar arch. The superficial palmar arch gives rise to the common palmar digital arteries, which give rise to the proper palmar digital arteries. The deep palmar arch gives rise to the radial artery of the index finger, and so in terms of the pathology, we're going to split up the conditions of the wrist into simple categories, which include autoimmune inflammatory, neuropathic musculoskeletal trauma, and miscellaneous. Next, we're going to talk about pattern recognition of different arthritides. So there are 3 major arthritides that affect the hand and wrist, those being osteoarthritis, rheumatoid arthritis, and calcium pyrophosphate deposition disease, otherwise known as pseudogout. So these diseases affect different types of joints commonly. So for osteoarthritis, you have more involvement of the proximal interphalangeal joints and the distal interphalangeal joints, with the relative sparing of the metacarpal phalangeal joints. Rheumatoid arthritis, you see more involvement of the metacarpal phalangeal joints and the proximal interphalangeal joints. And with calcium pyrophosphate deposition disease, you see less involvement of the smaller joints, like the interphalangeal joints, but more involvement of the bigger metacarpal phalangeal joints. This picture demonstrates different areas of the wrist, and those being the first carpal metacarpal junction, the common carpal metacarpal area, the scaphotrapezial area, the midcarpal region, the radiocarpal region, and the distal radial ulnar junction. And based on these regions, you can see different involvements depending on the arthritide, the type of arthritis, with osteoarthritis, you see involvement of the first carpal metacarpal junction and the scaphotrapezial region. With rheumatoid arthritis, you see more diffuse involvement, and with pseudogout or calcium pyrophosphate deposition disease, you see involvement of the. So this is just a radiograph depicting changes that would be seen in a patient with osteoarthritis. So you can see some osteophyte formation and decreased joint space. And this is involving largely the proximal and distal interphalangeal joints. So for rheumatoid arthritis, you can see periarticular osteopenia and marginal erosions of the joints, which can be seen here and here. and this x-rays of the foot, but similar changes can be seen in the hand as well. Calcium pyrophosphate deposition disease or pseudogout, you can see calcifications in the wrist joint. Next, we're going to discuss rheumatoid arthritis. These are caused by autoantibodies formed against the synovium. So you have anti-cyclic citrulated peptide and rheumatoid factor IgG that is bound to antigens, which activates plasma cells to provide large amounts of IgG, which activates T cells and cytokines that produces the inflammatory response against the synovium. It's usually found in Caucasian women. Etiology is unknown, however, largely it's considered a combination of genetic and environmental factors. Smoking does increase the risk of rheumatoid arthritis, as well as having a family history may increase the risk by 3 to 5 times. Common signs and symptoms include morning stiffness, diffuse swelling, and symmetric arthritis. The wrist and hand are common in this, and you can see ulnar deviation, which can be seen here. You see Boutonniere's deformity here. And that is the hyperflexion of the PIP and hyperextension of the DIP joint. You can see swan neck deformity, which is the opposite of Boutonniere deformity, which is hyperextension of the PIP and hyperflexion of the DIP. You can also see a Z thumb, which is hyperflexion of the first MCP and hyperextension of the interphalangeal joint of the thumb. You can also see lung fibrosis, atherosclerosis, and rheumatoid nodules. Rheumatoid nodules are basically depositions of fibrin that have a central area necrosis. Common radiological findings include periarticular osteopenia, which can be seen here and here, as well as marginal erosions. So in terms of classification criteria of rheumatoid arthritis, this was developed by the American College of Rheumatology. Basically aids in diagnosis of rheumatoid arthritis. It involves 4 categories: joint involvement, serology, and acute phase reactions and duration. You're largely looking at the joint involvement in terms of how many joints there are and what type of joints, so large versus small joints. For serology, you're looking at rheumatoid factor and anti-cyclic citrulated peptide. And then you look at CRP and ESR as well as duration, and a score of 6 out of 10 is suggestive of rheumatoid arthritis. Treatment-wise, you can have short-term treatment with NSAIDs and glucocorticoid injections. However, in the long term, you want to use disease-modifying antirheumatic drugs. Most commonly used are methotrexate and sulfasaline. However, it's possible to use TNF-alpha inhibitors as well. Severe joint involvement may require actual synovectomy. Next, we're going to discuss psoriatic arthritis. This is a seronegative spondyloarthropathy associated with HLA-V27. 30% of people with skin psoriasis will experience it. Usually occurs after the appearance of the rash or skin changes. However, 15% of the cases, the arthritis can appear before the rash. And we know some common signs of psoriatic skin changes, which include nail changes or pitting, silver plaques on the extensor surfaces, etc. Psoriatic arthritis presents as pain, diffuse joint swelling, usually oligoarticular or less than 3 joints, and is asymmetric in 70% of cases. Polyarticular or multiple joints greater than 3, 25% of the cases, and symmetric, as well as arthritis mutilans, which is severe destruction of the joint in 5% of cases. Ankle, wrist, digits, DIP mainly, and the sacrum are the most common areas associated with psoriatic arthritis. Diagnosis is clinically and involves ruling out other causes of arthritis, including rheumatoid as well. radiological findings, you'll see periarticular erosions, sometimes severe destruction of the joint, which can be seen in the MRIs here, A and B, as well as soft tissue swelling. Treatment is similar to rheumatoid arthritis, involves NSAIDs, methotrexate, TNF-alpha inhibitors, as well as phosphodiesterase 4 inhibitors, which is the most recent treatment. Osteoarthritis, this involves the wear and tear of a joint, so over time with increased weight bearing causes degeneration of articular cartilage, which causes bone-on-bone contact. So this is a non-inflammatory condition associated with obesity, which has an earlier onset. Usually involves large weight-bearing joints like the knee, hip, but can also affect hands and wrists. Morning stiffness is usually a hallmark that improves during the day. Pain, minimal swelling, and it's usually asymmetric. A common finding in the hands include Bouchard's and Herbendon's nodes, which are pointed out here. So Herbendon's nodes involves the DIP, and the Bouchard's nodes involve the PIP. And you can see the decreased joint space here and here. And you can see osteophyte formation as well, which are spurs that arise. In terms of classification and diagnosis, it's usually a clinical diagnosis with X-ray findings showing joint space narrowing, osteophyte formation, and subchondral sclerosis. You can also use the Kellgren-Lawrence classification scale for osteoarthritis severity based on radiographs. So scale of 0, no radiographic features of osteoarthritis. 1 is doubtful narrowing of the joint space, possible osteophytic lipping. 2 is possible narrowing of the joint space, definite osteophytes. 3 is definite joint space narrowing, moderate multiple osteophytes and some sclerosis, and 4 is marked joint space narrowing, large osteophytes, and severe sclerosis with definite deformity of the bones. And usually when you get to Kellgren-Lawrence classification scale 4, you consider replacements. So treatment is lifestyle, weight loss, physical therapy, NSAIDs, and corticosteroid injections depending on the case, and then as mentioned before, knee and hip replacements for severe debilitating cases. Septic arthritis. So this involves a prior infection, prior arthritis, and IV drug use, which are major risk factors. Risk is an uncommon site. 80% are caused by non-gonococcal bacteria, staph or strep. 20% include gonorrhea. Diagnosis is clinical. Fever, elevated white blood cell count, acute onset, blood cultures 3 sets, and joint aspiration, as well as NAAT. And imaging is usually X-ray, ultrasound, MRI, usually is non-specific. Treatment in terms of antibiotics for non-gonococcal infections, usually use vancomycin. For gonococcal infections, use ceftriaxone. And here is a picture depicting classic skin findings of disseminated gonococcal infection. And here you can see kind of haziness of the joint, indicating inflammatory changes, and soft tissue swelling. Next, we're going to discuss gout. This is deposition of monosodium urate crystals. Most commonly affects the first MTP joint. Wrist involvement is very rare. Acute swelling and pain is usually a common sign. terms of causes, diet, including alcohol use, and genetics are major risk factors. In fact, genetics may account for 60% of the cases. Diagnosis, usually you look at synovial fluid analysis, which shows needles with negative birefringence. Hyperuricemia is also usually seen. Imaging is generally not recommended, but you may find soft tissue swelling, calcifications, erosions, destruction of the joint. In the top picture, you can see tophi formation here and here. And here you can see severe swelling and destruction of the joint here. Treatment, acute, you usually use NSAIDs, or if NSAIDs are contraindicated, use colchicine as well as steroids. For long-term relief, you would use allopurinol, febuxostat, or probenecid. Next, we're going to discuss chondrocalcinosis or pseudogout. This is deposition of calcium pyrophosphate dihydrate crystals. Knee and wrist are definitely more common than the smaller joints when compared to gout. However, the presentation is similar. There is genetic, dietary risk factors, as well as older age. Diagnosis, imaging can play a major role. X-ray can show calcifications in the joint space, usually more lateral, and the synovial fluid analysis will show positively birefringent. Next, we're going to discuss Dequervain's tenosynovitis. This is chronic degeneration and thickening of the tendon sheath of extensor compartment 1, which we discussed, which includes extensor pollicis longus and extensor pollicis brevis. Common risk factors include pregnancy, computer mouse use, and cell phone use. There is constant swelling and pain at the base of the thumb near the anatomic snuff box. So this is just a picture of the anatomic snuff box, which is between the extensor pollicis longus tendon and extensor pollicis brevis tendon. Diagnosis is clinical. You can use the Finkelstein test, where the patient grabs their thumb with their fingers and then ulnar deviates their hand, and you should have pain near that base of the thumb. X-ray can rule out other differential diagnoses, and MRI will likely show swelling around the sheath. And in terms of treatment, you can use wrist splinting, NSAIDs, physical therapy, and in severe cases, carpal tunnel syndrome, very, very common pathology. As we discussed the anatomy before, the carpal tunnel is composed of the transverse carpal ligament, which goes from the hamate pisiform to the trapezoid and the scaphoid, and within that you can get median nerve entrapment, and associated with diabetes, pregnancy, hypothyroidism, and computer use. Pain, numbness, and tingling along the median nerve sensory distribution is key, and atrophy of the thenar eminence can occur in severe cases. Diagnosis is clinical. You can use electromyography if in doubt. Ultrasound and MRI usually not recommended, but median nerves swelling is also a key diagnostic feature. So you can see in this MRI there is swelling, and this is the median nerve, and is being basically impinged upon as it enters the carpal tunnel, which can be seen here. So treatment include wrist splinting, corticosteroid injections, which are temporary, physical therapy or OMM, or surgery for constant symptoms, which include carpal tunnel release. Next, we're going to discuss common fractures. So for the distal radius, you have 3 types of fractures: the Coles, Smith, and Barton. For the Coles, you have posterior displacement of the distal fragment of the radius, and this is fall on outstretched hand. Smith, you have anterior displacement of the distal fragment, and this is the fall into the back of the hand. Barton's fracture is fracture through the metaphysis and epiphysis here, and that can happen dorsally or ventrally. You can also have something called a Dinofork deformity. In terms of diagnosis, you have x-ray, and then for severity you would calculate volar and dorsal tilt. So for the tilt, you would get the lateral view of the wrist, and you would calculate it by drawing a line from the highest point of the radius, distal radius, both dorsally and ventrally, like this, and then you would draw a line through the radius like that, and then draw a line perpendicular, and then calculate this angle here. And generally an angle of greater than 30 is definitely suspect for severe fractures that may require surgical intervention. In terms of treatment-wise, you would have reduction, internal fixation for severe Coles fractures. Watch out for compartment syndrome. That can be a serious complication that definitely requires surgical intervention. Other fractures include the scaphoid fracture, which is a fall into the outstretched hand, pain in the anatomic snuff box, and it's important to watch out for avascular necrosis, which is a common complication. So you can see a fracture here through the middle third. Middle third is the most common area of fracture. In terms of other fractures, the proximal third takes much longer to heal, like 12 to 24 weeks, when compared to the distal fractures that occur, which may heal in 6 to 8 weeks. A fifth metatarsal or boxer's fracture is common in young men. You can see here. Lunate fractures are less common than scaphoid. However, there's also an increased risk of avascular necrosis or Kienbach's disease, and you can see the fracture of the lunate here. Skier's thumb or gamekeeper's thumb. It's a tear of the ulnar collateral ligament, and usually leads to an avulsion fraction of the proximal phalanx of the thumb. Pain and weakness at the first metacarpophalangeal joint is common, so you can see the avulsion fraction here. Fracture here. More acute is easier to treat and heal. However, it can be chronic and with thinning of the UCL due to repetitive trauma, and it's much harder to heal in those cases. Treatment includes spica splint, physical therapy, NSAIDs, surgery for complete tears maybe. So Dupuytren's contracture, these are fibrous nodules and thickening leading to flexion contracture. It's usually of the third and fourth digit. Risk include European males greater than 50 and those who smoke. Diagnosis is mainly clinical. There's something called the tabletop test, where the patient lies their hand on a table. If they're unable to flatten their hand, it's considered a positive test. Imaging is usually not indicated. However, MRI may show fibrous nodules and thickening of the flexor tendons, which can be seen here with the arrows. Treatment-wise, you can have steroid injections or physical therapy for mild diseases. Those can have high recurrence rates, and there can be fast. So we're going to talk about ganglion cyst. So this is an accumulation of fluid within a tendon from an outpouching. There's something called a herniation hypothesis, in which the ganglion cysts form from outpouchings of either the joint capsule or a tendon. Risks include gymnastics. Usually the cysts occur on the dorsum of the wrist or fingers, usually the extensor carpi radialis brevis. It's usually asymptomatic, however, some cases can lead to carpal tunnel syndrome. Diagnosis is usually clinical. However, if there's any doubt, you can use ultrasound for any occult cysts. In this picture, you see an MRI with cyst. Usually treatment-wise is watch and wait. Most resolve within months. However, you can use surgical excision for any refractory cysts. Thank you for joining me for this lecture. It was a pleasure to give, and I hope it was helpful. Thank you.